Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. I used to believe that too, until I started counting. Counting the patients who went in for routine procedures and came out permanently changed. Not better, changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open-heart surgery but lost 6 months of her life to complications nobody had warned her about. I'm Dr. Omer. As a physician, my work is grounded in evidence, critical thinking, and a careful evaluation of facts. I believe in explaining complex issues by examining the available data, verified sources, and the broader context rather than speculation. Today, I want to walk you through what's really happening here, why it matters, and how the evidence helps us understand the bigger picture. Here's what nobody tells you. The older your body is, the harder it fights just to survive an operation, not the disease, the operation itself. Let me ask you something. If you take a brand new car and a car with 200,000 miles on it, and you put them both through the same stress test, do you expect the same result? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same timelines. That's starting to change, but not fast enough. Here's what happens inside an older body when it goes under general anesthesia. The heart has to work harder, the lungs take longer to clear the anesthetic, the kidneys slow down processing medications, and the brain, this is the one that surprises people, the brain becomes temporarily disoriented in ways that can last weeks or even months. Doctors have a name for it. Post-operative cognitive dysfunction, and in patients over 70, it happens far more often than anyone admits. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I have reviewed cases of 80-year-olds who bounce back faster than some 50-year-olds. Age is just a number, yes, but frailty is not. Frailty is a medical term. It means the body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number jumps to nearly 60% in those over 85. So here's the real question. It's not whether someone can survive the operation. It's whether they can survive the recovery. Those are two very different things, and that distinction is going to matter a great deal as I walk you through what I've found. Surgery is never just the hours in the operating room. It's the days, weeks, and sometimes months that follow. And for an older body already operating with diminished reserves, that recovery period is often where the real battle is fought. The first surgery I want to discuss is open heart surgery in frail patients, specifically coronary artery bypass grafting, or CABG. It's one of the most common major surgeries performed on older adults. The idea is straightforward. Your arteries are blocked, so we reroute the blood flow. For the right patient, it works beautifully. But here's what the brochure doesn't show you. Open heart surgery requires stopping your heart completely. The patient is placed on a bypass machine, a device that performs the work of the heart and lungs while the operation is carried out. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, mild diabetes, and cognitive decline, that bypass machine represents a serious assault on every organ in the body simultaneously. Published studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, and extended time on a ventilator. And here's something that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after surgery. So what's the alternative? In many cases today, there is one. It's called TAVR, transcatheter aortic valve implantation. It's a catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than open surgery, but far kinder to a body that needs careful management, not a battle. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your surgeon one question: am I a candidate for a less invasive approach? That question alone could change everything. The second surgery I want to examine is aggressive spinal surgery. Back pain in your 60s and 70s is nearly universal. In my review of the clinical literature, I don't encounter a patient profile over 70 that doesn't involve some degree of spinal complaint, and the solution being offered more and more often is spinal surgery, fusions, multi-level decompressions, hardware inserted up and down the spine. Now, I need you to hear this clearly. Some spinal surgeries are absolutely necessary. A spinal cord being actively compressed and causing loss of bladder control or paralysis requires immediate surgical intervention. But elective spinal fusion for chronic back pain in an elderly patient. The evidence is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. And the most common complications were not minor ones: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion start breaking down because the mechanics of the spine have been permanently altered. The hardware holds one section rigid, and the rest of the spine absorbs the price. What frustrates me most is the pain relief question. Studies consistently show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better outcome, boss, but with dramatically higher risk. One of my colleagues, a brilliant spine surgeon, once said to me, "Sometimes the best operation is the one you don't do." I think about that often. The third surgery, and this one is the hardest to discuss, is major cancer resection. When someone hears the word cancer, the instinct is immediate and powerful. Cut it out, remove it, get rid of it. I understand that completely. But what 2 decades of reviewing surgical outcomes has taught me is this: the goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite. Let me walk you through a specific example. Pancreatic cancer surgery, known as the Whipple procedure, is one of the most complex operations in all of medicine. It involves removing the head of the pancreas, part of the small intestine, the gallbladder, and part of the bile duct. The surgery itself takes 6 to 10 hours. In younger, healthy patients, it can be life-saving. But in an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed, the tumor is removed, and yet the patient still passes away within weeks, not from cancer, but from surgical complications. This is called futile surgery, and it is more common than anyone wants to admit. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what researchers call failure to rescue, meaning a complication occurred that the weakened body simply could not overcome. So what's the conversation worth having? Ask your oncologist this directly. If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never knew existed, and sometimes the answer behind that door is genuinely better. The fourth surgery I want to address is elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that without reservation. For the right patient, a new hip genuinely transforms quality of life. People go from barely walking to playing with their grandchildren. The outcomes can be remarkable. But here is where it gets complicated for older adults. The word elective means the surgery is planned, not an emergency. You have time to think. You have time to prepare. And crucially, time to ask whether this is the right moment for your specific body. Because the statistics are important here. In patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries significantly elevated risk of perioperative complications. Blood clots are the biggest danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening pulmonary embolisms. In elderly patients with reduced circulation, this risk is substantially higher than in younger patients. Add postoperative pneumonia from immobility, add hospital-acquired infections, and the picture becomes much more complex. I want to be precise here because I don't want to discourage anyone from a surgery that might genuinely help them. The question is not whether to ever have a joint replacement. The question is whether your body is in the best possible condition right now. Optimizing blood pressure, blood sugar, weight, and cardiovascular health before elective surgery can reduce complication rates dramatically. Some hospitals now require a formal prehabilitation program before scheduling these operations for high-risk elderly patients, and that is exactly the right approach. Most patients have never even heard the word prehabilitation. They absolutely should. The fifth surgery on this list is emergency abdominal surgery. I need to pause here for a moment, because this one is different from the others. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation in an office. But here's why it belongs on this list. Knowing the risks in advance, before an emergency happens, changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgical teams are unskilled, but because an elderly body under sudden trauma is fighting on too many fronts at once. The liver, kidneys, heart, and lungs all get stressed simultaneously. And the inflammatory response that a younger body controls within days can spiral in an older body into systemic inflammatory response syndrome, a cascading failure that is as serious as it sounds. So what can you actually do with this information? Two things. First, do not ignore abdominal symptoms. Persistent pain, bloating, and changes in bowel habits in someone over 60 deserve prompt medical attention. Catching problems early means treating them before they become emergencies, and that one habit can change everything. Second, have the conversation with your family now, not in a hospital corridor at midnight. Now, what are your wishes if emergency surgery becomes the only option? What quality of life matters most to you? These conversations are not morbid. They are one of the most loving and responsible things you can do for the people who may one day be standing in that corridor making decisions on your behalf. Now let's talk about what you actually do with this knowledge, because information without action is just anxiety. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Write these down. The first question: what happens if I don't have this surgery? A good surgeon will give you an honest answer. If nothing urgent changes in the next 6 to 12 months, you have time. Time to think, time to seek a second opinion, time to optimize your health before committing to anything. The second question: is there a less invasive alternative? Medicine has changed enormously in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions, options that didn't exist a decade ago are now available in most major hospitals. The third question: what does recovery realistically look like for someone my age and my health profile? Not the average patient, you, your heart, your kidneys, your current medications, your living situation. The answer should be specific, not generic. The fourth question, and this is the one most people never think to ask: what is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If they seem uncomfortable with that question, that discomfort itself is information worth having. Before I close, I want to leave you with something genuinely hopeful, because this is not about fear. It's about options, and those options have never been more powerful than they are right now. Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures with small incisions, camera-guided techniques, and robotic-assisted surgery allow precision that dramatically reduces recovery time and surgical trauma. Catheter-based cardiac interventions have opened doors for patients who would never have survived traditional open surgery. Beyond surgery itself, and this is something I wish more patients heard, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a surgical approach. The body wants to heal. Sometimes the most important clinical decision is simply to give it the right tools and get out of its way. I want to share the case of a patient I'll call Gerald. He was 71 years old, a retired engineer, sharp and thoughtful. He came to me after 3 different surgeons had recommended open heart surgery for a blocked coronary artery. 3 surgeons, 3 recommendations, the same answer every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He had watched his wife go through a major operation 2 years earlier and come out confused, exhausted, and never quite the same person she had been. He looked at me and said, "She went in as my wife and came out as someone I had to take care of." That sentence has stayed with me ever since. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat with him for 40 minutes, not 15, and I told him the truth. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation. The data for his specific profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He's standing at the top of a hiking trail in Colorado with his two granddaughters, both taller than him now, grinning like he's won something that cannot be measured in clinical metrics. Here is what I need you to understand, and this is the single most important thing I want you to take from today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you have the right to ask every hard question, to request every alternative, and to take every day you need to make a clear-eyed decision. The surgeon holds the scalpel, but you hold the choice, and that choice, made with full information and without pressure, is the most powerful tool in medicine. More powerful, in my view, than any operation ever performed. To bring it all together, 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients where less invasive alternatives now exist. Aggressive spinal fusion, where the evidence for meaningful pain relief is far weaker than most patients are told. Major cancer resections, where the goal must always be more good years of life, not just the removal of a tumor. Elective joint replacement in severely ill patients, where timing and preparation matter as much as the surgery itself, and emergency abdominal surgery, where the best protection is catching problems early and having honest conversations with your family before an emergency ever arrives. None of this means avoid all surgery. Surgery saves lives every single day, and I believe deeply in its power when it is applied thoughtfully and at the right time. The message is simply this: be an informed patient. Ask the hard questions, request the alternatives, get a second opinion, and if necessary, a third. Your age is not a weakness. You deserve a surgeon who explains everything clearly and a medical team that treats you as a partner in your own care. Everything I've shared today is grounded in published research, clinical data, and evidence-based medical analysis. I have drawn on peer-reviewed literature, findings from major surgical institutions, and established clinical guidelines to give you a picture that is as accurate and balanced as possible. But every person's situation is unique. Factors I cannot know from here, your specific diagnoses, your medications, your functional status, your personal values, all shape what the right path looks like for you. Before making any decision about surgery or treatment, please have a full, honest, and unhurried conversation with your own doctor or specialist. They know your history. They know your body. And that conversation, informed, direct, evidence-based, and free of pressure, is exactly where good medicine begins.